whole social aspect of health care. The bottom line, the way we see it in West Virginia, is very few people have a value because they don't pay for it. It's always somebody else that's paying the bill. And when you don't have a value, sometimes you'll overuse it or misuse it. With that being said, and as a cultural, if we don't put as much emphasis on wellness as we do on repairing you when you're broke, the cost can get out of hand. And we think that's what's happened. The consumer is not in the market. It's the only service in America that you and I don't shop. We don't really look at our bill that close. We don't really understand the bills because they keep coming at you 6 months and maybe a year later. And before, all you care about is that I satisfy my copay. I've said something very simple, that why don't we have universal billing? Why don't we all agree that the first piece of legislation we should pass to get the market back and market forces working is that any medical procedure you have anywhere in America has to be a complete, concise, and itemized bill that you and I can understand. So maybe I can ask the question, that 5-minute visit cost me $275? Could it not be maybe a little bit more competitive? And are you sure that pill was that costly? And I don't remember getting that blood test. We have nobody in the market. We're trying to control something that's so big, and we've got nobody trying to help us control it. And everybody's on one side winning, and the other people that are paying, you know, we've always said in the political world, if the constituents, there's no constituents favoring the change because no one really cares. We did something in West Virginia called, we asked for a waiver for Medicaid called Mountain Choices. And we called it Mountain Choices. We have a lot of people basically that if you're on Medicaid, you don't get your eye care. You might not get dental care unless it's pain and suffering. But if we said, if you will enter into a healthy lifestyle choice, if you'll go to your doctor's visits and not use the emergency room when it's not needed, you can start earning points and rewards for glasses, for health care. And the cost starts coming down because there's a value. There is that reward system. And we're trying to expand on that. And when you hear us all talk, we talk about flexibility. Because as Governor Bredesen just said, he inherited a program that had all the good intentions. All the costs got loaded to the front end, and then the savings never came from the back end. And everybody else was sacrificing in his society to make up for the costs that they couldn't reduce. We're trying to prevent that. And if you hear us talking, when we say flexibility, before we expand, make sure we can live within our means.
This is a really important point, and you've said a lot of very critical things to the national discussion, about the national discussion, because what we've been hearing a lot about is really health insurance on a national conversation, and not necessarily health care, which is why I'm so delighted and really thrilled that the First Lady, Michelle, has taken on this issue of child obesity to really get into early on the issues and prevention, and so that we don't spend as much as we do later on in life on these preventable diseases. Thoughts on this issue from the table as far as expanding care and prevention and putting things in place sooner rather than later to get a handle on costs?
Thank you, Maria. Jennifer Granholm from Michigan. We in Michigan, we wanted to model ourselves after a plan that worked, because obviously, if you open up Medicaid to anybody who comes, you're going to be taking on a lot of expenses, and so you have to figure out on the front side, how do you do the prevention and the primary care? How do you make sure that people have a stake in this so that there's a shared responsibility? How do you make sure that the benefit package is one that you can afford? And how do you make sure that it's transparent? So we looked at Massachusetts because they had done a huge effort in healthcare reform. And it required some cooperation on the part of the federal government, and there was a shared responsibility both of individuals and businesses and government. And to me, I'd love to hear from Governor Patrick about how that's worked in Massachusetts, because I think that's a model that we can all look at as governors if, in fact, it's been successful. And what would you change?
We didn't work this out in advance, just to be clear.
No, this is perfect. Thank you so much, Governor Granholm.
But thank you for the setup. We have a hybrid system, as you may know. It's a combination of both market and public contributions. It builds very much on a strong private insurance market in Massachusetts. It was invented on a bipartisan basis under the leadership of my Republican predecessor, a Democratic legislature, Senator Kennedy, and at the time the Bush administration, which was absolutely essential in terms of approving the Medicaid waiver. And the implementation fell to me starting on the very first day in office, and we have now nearly 98% of our residents insured today. I don't think there's another state that can touch us. Jim Douglas is coming on strong from Vermont.
He's catching up.
He is. He won't catch us, but he is making progress.
We'll see. We'll see.
We had some, just to Joe's point, though, Joe Manchin's point, everybody starts from a different place. Because we were using so many other patches and plugs in the healthcare safety net, if you will, in other elements of the budget. A universal system in the reform that we pursued has added only about 1% to our total budget. And we have saved in the uncompensated care pool and moving people out of emergency room primary care to primary care settings, which is huge. But the big pickup and the remaining challenge is cost control, and that's not unique or even special to Massachusetts. That's everybody's issue. And to the premise of your question, your last comment about prevention, that's an absolutely critical part of it. There is a responsibility, and as we talk about shared responsibility, there is a responsibility that individuals and families must take around wellness, so that we can move to a healthcare system and away from a sick care system, which is what we have today. We have some ideas around cost control, particularly around payment reform, that we're looking to implement right now and that we talked about in yesterday's session. But it cannot be understated the importance of each of us doing what we can to look after our own health and our own healthy choices.
Actually, Governor Manchin made a good point, because in other areas of our lives, there are repercussions and implications for your behavior. In car insurance, if you get into a lot of accidents, your insurance goes up. So the point that you make is duly noted, really, really important. Governor Pawlenty.
Thank you, Maria. It's just some things that have worked in Minnesota that may be helpful for the discussion. One is we have the highest concentration of health savings accounts in the country in Minnesota. And for those who participate, we've been able to document some relative savings, which has been a good thing, and they've helped contain costs in our state. We have another program that we've put together with our state employees around payment reform, and we've said, look, people tend to spend money differently if it's their own money, or at least some of it's their own money. Now, they need to have guardrails in place for consumer protection, but we said to our state employees, you can go anywhere you'd like, but if you choose to go somewhere that is poor in quality and high in cost, you're paying more. And if you choose to go somewhere that is more efficient with respect to costs and higher in quality, you'll pay less. 90% of them, 90, have migrated to higher quality, more efficient providers. And in 3 of the last 5 years, the premium increases in that program have been 0%, and in the other 2 years, close to 0%. And that's on fairly primitive measurements of cost and quality, and the ability to make that even more advanced is progressing very nicely. So we're going to have even better look into that in the future. So that has worked nice. We have another program called Q-Care, which we've said for all of the public programs that we pay for health care, we're going to begin to pay for performance. We're no longer going to pay just for volumes of procedures in diabetes and heart disease and some other chronic care conditions. We expect the practitioners to follow best protocols and achieve better outcomes, and if they do, they get a financial bonus, and that has some early promising results. And then lastly, in the medical malpractice area, there's lots of ideas for reform here, but clearly some improvement can be made. We have a system that says if you're going to sue a health care provider, a doctor, for medical malpractice, you have to submit an affidavit at the front end from another doctor in good standing in our state indicating that there's reason to believe malpractice occurred. And now we'd like to take that to the next step, where it's not just a doctor, but a specialist or a subspecialist in that same area, if it involves a specialty practice, making that same affidavit. That's been a very good gatekeeping role to try to minimize or at least reduce frivolous lawsuits.